Good evening, everyone. A warm welcome to one and all. Thank you all for joining us on this beautiful evening. We've gathered here today to inaugurate the National Nutrition Month or Poshan Maha 2020. On behalf of Indian Dietetic Association Mumbai chapter, I invite one and all to enjoy this feast that's ahead of us for the next 2 hours. Before we begin with our program, I request everyone maintain a 2 minute silence in the respect of late husband of Miss Meena Prabhu, who was our ex-president of IDA Mumbai chapter. Unfortunately, we lost him a couple of days ago. And also in respect of our honorable president, Mr. Pranab Mukherjee.
But you will participate.
Thank you, everyone. No Indian program begins without ceremonious lighting of the lamp. We welcome one and all for the salutations of the lamp, which is symbolic of knowledge, enlightenment, hope, and progress. As we light the lamp, I invite the dignitaries to pray along with us for this very auspicious occasion.
Shanti, Shanti, Shanti.
O Lord, take us from the phenomenal world of unrealistic expectations towards reality. Take us from the ignorant state of darkness towards light. Take us from the world of mortality to the world of immortality. That is what this beautiful Sanskrit poem says. Om Shanti. With this positive note, I would now request Ms. Zamrut Patel, the convener of Indian Dietetic Association Mumbai chapter, to address the audience and welcome the gathering to the celebration of National Nutrition Month.
Thank you, Sukhuda. Friends, warm welcome to one and all from Indian Dietetic Association Mumbai chapter, and also a very happy Teachers' Day. Today is Teachers' Day and we are very happy at Indian Dietetic Association Mumbai chapter to have been inaugurating our first program of the Nutrition Month on such a good day. So the theme of our workshop today, our seminar, is on eating disorders. People feel eating disorders are not common, but this is not true. Eating disorders are today very common in adolescents, and I would also say in adults. So today's seminar is on the psychology and dietary management of eating disorders. We have already uploaded expert talks from Dr. Himani Kashyap and Dr. Sabina Rao on the psychological aspects of these eating disorders. And we are very fortunate today to have with us Dr. Mirin to talk on this topic. So, but before we start our program, I would want to welcome our National President, Dr. Jagmeet Madan ma'am, to this webinar. Welcome ma'am to this webinar. Ma'am needs no introduction to the Mumbai chapter team. She is our mentor, and ma'am is here to be talking to us about the theme of the Nutrition Month. So I would request ma'am to just say a few words of wisdom to us, our team, and also to throw light on the theme of the Nutrition Month this year. Ma'am, please.
Dietetic Association. And warm greetings, Dr. Marcia Heron. We are privileged to have you with us today, and so very thankful that you could take out time and be with us on this special day. Indian Dietetic Association is one of the largest association of India, with close to 20,000 life members, with a pan-India presence of 25 chapters across India. So you can imagine the strength, the penetration, the reach this association has. And Nutrition Month, or what we call in Hindi, Dr. Marcia, I do not know how much of Hindi you understand, but I'm going to use some words. So it's called Poshan Ma, and which means Nutrition Month. And it's a very special month for all of us nutritionists in India, where we look back in terms of what we did last year. And every year, this month comes with a theme, which kind of pushes us to introspect and, consolidate our efforts to work on those areas which are actually national priorities. So these themes come from the Ministry of Health and Family Welfare, and our President, Mr. Narendra Modi, is an ardent believer of the role of nutrition in the nation's well-being. And he has initiated Poshan Abhiyan, which is a very important national movement. And there is an Eat Right India initiative, there is Fit India initiative, and everywhere we are talking about eating right, eating safe, eating sustainable. So this year, National Nutrition Month, or Poshan Ma's theme has two threads which are very important. One is the severe acute malnutrition, because in India, this is something which really we need to ponder about, and we need to prevent a lot of our children getting into complications because the SAM detection may get delayed. So I think the endeavor is to detect SAM at an early stage and prevent the adversity it can bring in the child's life. So that's where the child feeding practices, the exclusive breastfeeding, and all the efforts towards early childhood feeding are going to be emphasized. And not only that, even the identification of these children, very important. The second thread of this Nutrition Month is promoting kitchen gardens, or in Hindi we say paudhe se poshan. So that means you try to develop ways by which you can grow local, you can grow seasonal, and you can enrich people's diet through these efforts. So I think this is another mandate which Indian Dietetic Association has taken nationally, and we are encouraging people, even in times of pandemic, if you can create a little place in your window and you can grow your little herbs or a few things which will add value to your diet, I think it will be a huge contribution. So these are the two themes with which Indian Dietetic Association is working pan-India, and I'm extremely happy and thrilled to see the vibrance across different chapters. And you will not believe this is the third or fourth program in this day, wherein I'm a part of different chapters. And because of the fact that we are virtual, and so distances are no problems. So it's like an omnipresence or a universal presence. And because of this virtual platform, Dr. Marcia, you are with us here. So extremely grateful, and I'm a part of Mumbai chapter, and it's very, very close to my heart. So and it's a most dynamic chapter of IDA, wanting to do things, and very, very dynamic leaders and members. So I wish you all a very good luck with this inaugural program, and I'm sure you're going to do really well in this whole month. Thank you so much for giving me this opportunity.
Thank you very much, ma'am. And we really look forward to you. And over to now the conveners of this webinar, Sukda and Anaga. Over to you, Sukda.
Thank you, Dr. Madan, and thank you, Ms. Patel. It's a pleasure that, to hear such stalwarts speak about the objectives of the Poshan Maha or the National Nutrition Month. We do have some programs lined in with respect to these themes as well. But today, on choice, we've chosen this topic of eating disorders. Often when we spoke about eating disorders, people would say that it's not very prevalent in India. And that's why the weightage that was given in the curriculum was also very small. There are very few Indian studies which talk about the prevalence of eating disorders in India. And if you look at it, we have prevalence ranging from a few points to up to 26% of prevalence that is seen in the population or the students that were interviewed with respect to eating disorder. So, under this NutriBulletin series, which is what we have planned for evidence-based talks on different medical nutrition therapy topics and clinical conditions, we bring to you a webinar on eating disorders. So they say that the prevalence is less. Whether the prevalence is less or whether the awareness is less, that's really the big question to ask. In Mysore, which is south of India, a study was conducted in a few college-going kids. Around 1,600 kids were interviewed, and they found that around 26% of the population had eating disorders due to an abnormal eating attitude. Now, in India, if you see, the term foodie is used quite loosely. It is used to describe every Indian who loves food. Okay, and we eat, as Indians, we eat food to rejoice, we eat food to mourn, and we eat food when there's nothing to do as well. So we associate very closely with different kinds of food. Also, a lot of us, when Indians, when we meet, no matter which community, which part of India you're from, when we meet each other, often instead of asking, oh, how are you? We would say, oh, you seem fine. You seem to have put on a little. Oh, you've lost weight. That's how we address each other. Now, with that in mind, perhaps all of these, when I listen to the talks of Dr. Sabina and Dr. Himani, I realized that these are some of our attitudes probably, which could predispose us to having certain kind of abnormal eating attitudes, because we're so conscious of the way we eat, the way we look. Eating disorders begin with an emotional health problem. So we have a keynote speaker again with us, Dr. Marcia Herring. She has a doctorate in nutrition education and master's in public health nutrition. She's a founder of the Dartmouth College nationally renowned eating disorder treatment program for college students. She's a clinical professor at the Dartmouth Medical School with an appointment in the adolescent medicine faculty. She provides training to pediatric residents at Children's Hospital at Dartmouth. She's a lecturer worldwide and carries out nutrition counseling in the treatment of eating disorders. And she conducts workshops world over. Just last week, she had a workshop in Russia as well. Dr. Herring provides pragmatic and clinical supervision for eating disorders providers from in US, UAE, Britain, Mexico, Russia, Ukraine, and Venezuela. And she's been dealing in the field of eating disorder for the last 30 years. She has authored many books on this topic. She's also honored as a fellow in the Academy of Eating Disorders in 2013. At the University of California, Berkeley, she received her master's degree and completed a dietetic internship. And she credits much of her success with patients with eating disorders and weight issues to her own struggles with the recovery from these conditions. So we welcome you, ma'am, once again. And if we can quickly do one poll before you begin. So I just want to see our audience, how many of them see eating disorders in the practice. So if we have an idea. So we're going to quickly run a poll. I request the audience to take the poll. How many of you see patients with eating disorders in your practice? So we have quite a few students joining in today who are dietetic students, and it's going to be very relevant for them because like I was saying, I'm not quite sure at what part I got cut off. So eating disorders, like we said, that it probably the prevalence is not less, the awareness is less, and it's important for us as dietetic professionals to identify these signs of eating disorders and refer to the right professional so that our adolescent teenagers, get help at the right time. So we have around 18% of our subjects who are, from our audience, roughly around 18% are the ones who are seeing eating disorders patients. So that's not quite bad. All right, so I'm going to start with your presentation, ma'am.
Great.
Are you able to see the screen?
I am, thank you.
Yeah.
Well, I know a little Hindi because my son-in-law is from Pune. And I eat a fair amount of Indian food when I get a chance. And my real sadness is I can't visit you all in person. So next slide. Well, while they're figuring that out, I can't do a thing about it, I'm happy to say. Dr. Rao said a few days ago in her very interesting talk that eating disorders are interesting for dietitians. And I agree and have devoted my professional life to treating them. I tell my patients that I had my eating disorder so long ago that neither I nor my doctor knew what I was suffering from. And my hope for my patients is that they will receive better treatment than I did, which was none. And I have a real passion for training and interesting dietitians in doing this work because it is so important. You know, eating disorders are a psychological disorder, but they have to do with eating and with food, and that's where we come in. Let's see how there we go. Thank you. We're all caught up. Dr. Kashyap described the various psychological treatments for eating disorders. I'm going to highlight the nutrition treatment of eating disorders. Our primary goal is helping patients restore, if necessary, and maintain a biologically appropriate weight. To be honest, I have coined this term, but it's really taken off. And this is a primary goal, of course, of patients with anorexia nervosa. We dietitians also focus on normalizing food and exercise behaviors, and we help treat body image disorders by modeling and supporting acceptance of one's natural body weight and shape, and introducing aspects of body image therapy that Dr. Kashyap also mentioned, and supporting those in our work with the very same patients. Next slide, please. Features of a biologically appropriate weight. This is the weight that you were meant to be. Not so long ago, we've learned a lot about set point, a predetermined genetically mediated body weight that each of us is programmed to reach and maintain as an early adult. And of course, as life goes on, all sorts of things go on, but that's another story. This is a weight that's maintained with ease, without special dietary concern, without dieting. And if one is young, it supports normal health and growth. A major sign of normal health and growth is puberty and menses. Often patients with anorexia lose their menstruation. And normalization of thoughts. So there's not such a focus on body size and shape in food. In the US, we use these BMI growth charts, and they're very helpful. They're used worldwide. I'm sure they're used in India. And you can see this patient needed to gain about 20 kilos to get back, as we say, on her growth curve. You can see where she was going along, and then boom, started at just past age 10. At 12 and a half, she was at her lowest, and then she returned to a healthy weight for her. Next slide. Your conference is based on encouraging dietitians to use evidence-based treatment. That is so important, that we don't just make things up because they sound logical or interesting or because we heard them on the internet. my book that I'm very proud of, Nutrition Counseling in the Treatment of Eating Disorders, which I really wrote for young dietitians that wanted to get started in this field, is based on the evidence. I joke my hobby is reading scientific literature, and it is a fine hobby. The techniques we use in dietetic treatment come from evidence-based treatments and techniques. CBT, cognitive behavior therapy, and the newest and extremely effective family-based treatment, where we are training really the parents to refeed their child at home. Next slide, please. Next slide. There we go. I don't know, I grew up with a soup called alphabet soup. And I think I often do talks for dietitians talking about the alphabet soup of my dietetic treatment for eating disorders. Some emerging treatments are DBT, ACT, which is excellent for body image issues, and motivational interviewing, which is the one treatment besides cognitive behavior treatment that dietitians may well be trained in, and this helps us engage the patient. Next slide. What's important when you're working with a patient, and most of you know this, that we know what we're doing, that we have confidence, but that we're forming a relationship with our patient. Now, it's true, I don't always really like all my patients, but I need to enjoy them. I need to be interested in their experience. The dietitian's often working with a team, with a therapist, maybe a psychiatrist, and also a medical doctor, maybe an occupational therapist. Our job is to focus on what the patient is doing with their behaviors, not on why they have the eating disorder, not the family issues that might be behind the eating disorder. That's the role of the psychologist. Each session needs to be devoted primarily to food, weight, and body image. So I have a rule for myself. I start with those issues by asking, how did your food plan go? And I end with those issues, usually giving the patient some assignment to do at home that's related to food plan and some of these other issues. Let's talk about food plans. Next slide. These quotes are not from me, but a food plan is the most effective behavioral intervention in treating an eating disorder. This was written by a psychiatrist, an indispensable prescription, and that it inoculates patients against relapse and further eating disorders. So I make a very big deal about of the food plan I'm going to introduce. And sometimes I even say, drum roll, please. Next slide. There are many food plans. They're out there. In the US, a food plan that's probably most widely used is the Exchange Diabetic Food Plan, which was developed for diabetes, not for eating disorders. There's the My Plate, which is the US government's view of a guide to eating that frankly is really a diet. There's calorie counting, and My Plan, the rule of threes, that was kindly introduced when I was introduced, which was developed for treating eating disorders. Next slide. I introduce this plan to my patients sometimes by saying, when they ask me, how did you recover, Marcia, from your eating disorder? I had no professional treatment and no therapy until much, much later in life. I somehow had figured out this way of eating, and I eat it to this day. So I practice what I preach. It is regular balanced meals, as you could see. It makes nutrition and eating very simple. In the US, this is often how people ate. Grandparents ate 50 years ago. People were eating this way. And I tell my patients, when Americans ate this way, we didn't have obesity or eating disorders. One of the challenges in talking about nutrition, I think for dietitians, is that we're so proud of our knowledge about the research on nutrition and this new thing and that new thing. Forget about that when you're treating eating disorders. That's not our aim. It's to make eating simple, easy. I talk about our ancestors being able to eat well and survive, or we wouldn't be here today without knowing a single thing about nutrition. And eating needs to be that simple. There's some background noise. I'm good at ignoring things. Someone with an eating disorder, particularly anorexia, may need to begin, and maybe for a long time, to eat by the clock. I call this the rule of threes because there's 3 meals and there may be 3 snacks. Very difficult to gain weight if one needs to gain weight without eating snacks. The big surprise to my patients is this food group I call fun food. It is the most important part of this. It's the game changer. It's why this plan works so well for treating eating disorders. Next slide, please. I call it fun food because it may be a dessert, it may be a cupcake, it may be cookies, but there are some people that really prefer the taste of salt for fun than sugar. I like both, frankly. And so it could be a food that's high in salt that's fun for the patient to eat. I tell my patients that my grandmother only gave me one bit of nutrition advice growing up, and it was brilliant. She said, save room for dessert. And I use this now in treating, I also work with obesity. It protects against overeating at meals. You're going to have this lovely treat at the end. You don't want to eat too much because you don't want to be too full. Patients with eating disorders are often very fearful of foods in this category. Part of their recovery is being exposed to these foods and eating them and realizing they don't cause binge eating, they don't cause weight gain. And this line is from one of my patients, and it's why I really began introducing fun foods into my treatment early on in my career, because patients would tell me coming out of the hospital when I would ask them, what was the most helpful thing? They required us to eat dessert at every meal. Next slide, please. Hunger and fullness, mindful eating. This is irrelevant in an active eating disorder. All of that is dampened down, corrupted by the eating disorder. It may or may not be something the patient can eventually do. Often the patient with anorexia it's not a very mindful person, frankly, and they may do better just eating I need to eat my 3 meals, I need to eat my planned afternoon snack. So we don't focus on mindful eating or hunger and fullness till much later in treatment, and only if the patient is interested. Next slide. Part of nutrition treatment usually is doing weight checks with patients. In many team situations, it's the dietitian that's doing the weight check. Sometimes it's the doctor, and if that's the case, it needs to be communicated to the dietitian. What I say to my patients is, your weight check is a direct message from your body to both of us about how it is doing. It's easy to measure, it's fairly accurate, and it's often something the patient is afraid of and worried about, and so they need exposure to it. The standard treatment or approach to weighing patients is called collaborative weighing, which means that we, as the professional, are doing the weight check with the patient. They're seeing their weight and we're talking with them about it. Next slide, please. As I said, the scale is how your body speaks to me, and weights are taken facing forward. For decades, the standard treatment was to have the patient stand on the scale backwards. They did not know their weight. It was something that was thought of as triggering the eating disorder. But the truth is, those of us that work with eating disorders or have had them know that we were thinking about our weights all the time. So doing it blindly was no help at all, as it was called. We know that there's some very simple, as my patients call it, caloric math. If you need to gain weight and your weight hasn't gone up, add 300 calories every day to your plan for 1 week. If your weight doesn't go up, we add it again for the next week. If weight is lost, you add 500 calories to the plan. And we're aiming for, it's not on the slide, but I think it's interesting, the rate of weight gain that's associated with complete recovery and quick recovery is 0.5 kilo a week. Now, when I'm working with obese patients, I'm hoping for 0.5 kilo a month, because that's the rate of weight loss that patients can maintain for life. Next slide, please. Let's talk a little bit about binge eating, also a part of eating disorders. And with my patients, I talk about with anorexia that we call this the dirty little secret of anorexia. As anorexia goes on, most patients have experiences with binge eating, but it's not discussed about. Behind binge eating, we believe there's always deprivation, nutrient, calorie deprivation, and often psychological deprivation. You can see the difference between these two plates here. If a patient reports to me that she's binge eating, we have to increase your food plan. You need bigger meals. Are you eating all your food groups? And I can't help someone work on binging until they stop restricting, because it's behind binging. I can't help someone lose weight if they need to until they stop binging. So they need to eat really good meals, and back to the food plan they go. Next page, slide, please. Purging. This is usually self-induced vomiting, though it can be of the abuse of laxatives, diuretics, and over-exercise. It's really interesting, this excellent article, paper by Pike and Dunn, The Rise of Eating Disorder in Asia, found that purging, primarily through self-induced vomiting, in the context of anorexia and bulimia, was the most common eating disorder behavior found in India. And I'll be interested, and you may have some questions about that, how many of you that work with eating disorders find that purging is extremely common. In the US, less, with anorexia, I'd say less than half the patients purge. This paper would say that you should assume if you have an anorexic patient, they're also purging. One of the ways we address purging is to talk about some of the complications of purging. I actually had a patient swallow a toothbrush. She was many patients find that eventually it's hard for them to throw up, so they need to trigger the vomiting by using their fingers, or in this case, it was a toothbrush. The patient swallowed the toothbrush and had to be rushed to the hospital, and it had to be surgically removed. Russell's signs is a rash on the hands from violently triggering purging by forcing yourself to throw up with your fingers. Chipmunk cheeks, most patients who purge also want to be thin. You can see in this picture that her jaw is really swollen because the vomiting irritates the glands in that area. I have this slide actually of these teeth. They look pretty good because they're white and they're usually not, but you can see how worn away and jagged they are. That's very common because stomach acid is so strong. One of my patients who's a lawyer and her appearance matters to her very much, she told me she's been purging for 20 years. Tell your patients that it's going to cost her $50,000 US to have her teeth redone, because purging over 20 years has totally ruined her teeth. And purging leads to weight gain. The next slide will help me explain that. So yes, I made up this billboard. It doesn't really exist. But if everyone knew this, that purging does not get rid of calories, I argue no one would purge, because that's the reason they do it primarily. It also reduces senses of fullness. Next slide, please. So here are the facts. I went after this research because I found it curious that patients would come in and say, I started purging and it really helped me lose weight, and now I seem to be gaining weight. We don't have any research on new purgers because that would be incomprehensible of asking people to go into a study and learn to purge. So we could see how many calories are retained after they purge. So all of this research is on seasoned, experienced purgers. They keep 1,200 calories, no matter how big the binge was. Now, as a dietitian, I was just wowed by this. Dietetic students probably know that 1,200 calories is about the lowest someone can go and meet their nutrient needs. And diuretic abuse and laxative abuse have just a minor effect on calories. I also point out to patients that if purging really worked, people who purge would have horrific nutrient deficiencies, but there's no known nutrient losses associated with purging. Next slide, please. Now, my patients just can't believe this, so I share these studies with them. You can see they haven't been done recently, and no one seems interested in doing them, but I actually know Dr. K that did the first study, and he's a giant in the field, and I'm so thankful for it. Next slide, please. So I'm convincing some of you that this is an interesting field to go into. It is really important that if you're new to the field that you have what we call supervision. This is work with an experienced dietitian, possibly a psychologist, a psychiatrist who knows eating disorders that can help you reflect on the clinical dilemmas that come up while you're treating patients with eating disorders. And this is important because the person with the eating disorders needs to have full confidence in you. And let me say another few words, and I'm an example of this. There is the issue that dietitians might have had their own previous experience with an eating disorder. There have been studies that indicate dietetic students have higher rates of eating disorders than other young professional students. Whether that's true or not now, I can't say. Studies haven't been done recently, and studies have not been done of psychologists and psychiatrists, so not really fair to say that it's worse in our field. But you cannot treat eating disorders unless your eating disorder is something that is in your history, not current. And part of this is because people with eating disorders have radar. They can tell if someone else has an eating disorder, and you will lose all credibility. My patients tell me that I have particular credibility because I'm open about my own experience, and I have recovered and been recovered for, now don't do the math, you'll figure out how old I am, about 50 years. Next slide, please. So these are my tools. These are the books I have on my bookshelf. And if you're interested in treating eating disorders, I highly suggest you become familiar with these books. And way back earlier in the slides, I listed my email, and I hope that will be shared. I'm happy to share these slides complimentary to any of you in the audience that would like to have them, and then you would have these references. They are extremely helpful. The last book listed on this slide is A Guide to Medical Care and Complications. Dr. Phil Mueller, a personal friend and colleague of mine, has looked so carefully at the medical issues associated with eating disorders. And often the role of the dietitian is to interpret this kind of information for our patients so they know what their risks are. Next slide, please. And there's more. Here are some more tools. resources on this slide have to do with those emerging therapies I was telling you about, DBT, MI, and ACT for eating disorders. And I found them very helpful in keeping my treatment fresh, and also often my patients are working with therapists who are using these same treatments, and it keeps us all on the same page using the same language. Next slide, please. Now, my favorite books happen to be ones by me, myself, and I. And I've written a book for parents, which is very helpful, as I said earlier in this talk, that family-based treatment is all about training parents to kind of step up and be bold and strategic in insisting their child to eat appropriately at home. And for modern parents, particularly in the US, that is very difficult, and it's an art. This book is helpful to them. And my book on nutrition counseling, I held nothing back in that book. Everything that I do that I've found effective, I have shared in this book, so you could take this as a treatment manual that you could use. And that is the end of my talk. I hope we're still on time with our snafus with the technology earlier.
Yes, you're on time.
I'm good at that.
Sorry, you're on mute, Dr. Marcia.
Thank you.
Anaga, you're on mute.
So Dr. Marcia, we would really like to thank you for that extensive talk where you shared and touched upon every aspect of eating disorder, right from the evidence-based guidelines to how it is important to form rapport with your patients and how it should be what and not vibe. At the same time, thank you for sharing the food plans and emphasizing the fun foods and your 3-meal rule of 3 rule with us. Also, it is very important that you emphasize the mindful eating part, which is so essential. Thanks for sharing your experiences also with patients, and at the same time, how important is the role of supervision in this and the various tools that you referred. And thank you for sharing them with us. I'm sure it will be very important for our audiences and the participants too. So I would like to ask if our seniors would like to say a few words. Dr. Madan.
Anaga, I think we'll start with the panel and join us in the panel for questions. So,
Dr. Marcia,
yeah, ma'am, please go ahead.
yeah, it was an excellent, can you hear me?
Yes.
Okay.
Yes.
Okay. It was an excellent deliberation, and I think what you said very right. Your personal experiences and you know, the exact handling of patients, and you know, the kind of value additions which you gave from the practical value additions, I think they were very, very pertinent and relevant. So I think what probably the audience needs to gather is how to customize this in an Indian setting. Because we do find these eating disorders, and especially in younger age group as well. But you know, would you like to just comment on identification of this disorder in you know, the younger age group? Any cues or anything from your experience you think can be a takeaway message for the audience here?
Yes, it's very difficult, and I see a number of patients being missed. They're a child or an adolescent, and they go to the doctor and they've lost weight. I would argue no child, no adolescent should be losing weight. They're supposed to be growing. And one of the new developments in eating disorders is what we're calling, it's not a very good name, atypical anorexia nervosa. These are people who are naturally larger people, and they lose weight down to what you might call a normal weight, but they have anorexia, and their health risks are as severe and as complicating and as dangerous as someone that gets to a very low BMI. Now, these are the patients that often get missed. The doctor may say, the parents may say, as I was introduced, it's so great to see, young teenager, that you've lost 5 kilos. Good job, you're looking really good. And I would be very concerned about an adolescent that has lost weight.
Yeah, true. Very, very, very important point, brought in there. Yes, yeah. So thank you so much. Thank you so much for your response.
So as all of you know that on 2nd of September, we had released 2 videos on our YouTube channel by psychiatrist Dr. Sabina Rao and clinical psychologist Dr. Himani Kashyap. And their topics were respectively eating disorders, Indian perspective, and the psychology of eating disorders. Both the videos got us amazing response, and we had a lot of questions on that. So now we will begin with the Q&A section. But before that, I would like to introduce our 2 speakers who will be joining us for the Q&A along with Marcia ma'am. So can we have the screen, please? The series profile.
Are you able to see it, Ananda?
Yes, yes. So I would request Dr. Himani to please put the camera on, and Dr. Sabina Rao also to switch the camera on. So Dr. Himani Kashyap is an assistant professor of clinical psychology. She's a coordinator, Cognite Clinic, NIMHANS Center for Wellbeing at National Institute of Mental Health and Neurosciences, Bangalore. She is an ex-senior neuropsychologist at the Victorian Rehabilitation Center, Australia, ex-clinical neuropsychologist, the Melbourne Clinic, Australia, and ex-research fellow at National Neuroscience Facility at University of Melbourne, Australia. Her area of research interests include neuropsychology of psychiatric disorders, holistic psychological interventions for acquired brain disorders, cognitive training in psychiatric disorders, and psychotherapy and neuroscience. She's also on editorial board of Scientific Journal of Neuroscience and Indian Journal of Psychological Medicine. She's also a reviewer for many journals, national as well as international, and she's a member of Indian Association of Clinical Psychology. Our next speaker is Dr. Sabina Rao. She's a consultant psychiatry. Could you please go back?
Sorry.
Consultant psychiatrist at Columbia Asia Hospital, Sarjapur, Bangalore. She has over 14 years of experience. She's done her MD from Duke University, USA. She has extensive experience in assessment, diagnosis, treatment of wide spectrum of psychiatric disorders. She's proficient in therapeutic communication techniques for behavioral and emotional issues. She has initiated telepsychiatry at NIMHANS, benefiting over 1,000 patients. She's also responsible for the rehabilitation of mentally ill and mentally challenged patients, and she strives to make care affordable to the masses by providing the best care. So now we would begin with our question and answer session. Sukada, please initiate.
Yeah. Sorry, 1 second. Technology is funny at times. Yeah. So we have a lot of questions. We have a lot of young dietitians in the crowd. So I'm going to start with their questions first, because I think that makes sense to address their questions at the moment. So first and foremost, how does guilt add to the emergence of eating disorders? I think, Dr. Himani, if I could pose that question to you, how does guilt add to the emergence of eating disorders?
Is my audio fine?
Yes, ma'am.
So this is we say hello, right? Is my audio okay? Is my audio okay? It was wonderful listening to Dr. Masha Herin. This was very educated. And actually going to in answering and hello to Dr. Sabina as well. In answering this question on guilt, I'm actually going to go back to what Dr. Herin brought up in her presentation as well about how eating you must always be associated with joy, right? And like she said, when there is binging, it means that they're not enough to eat in in terms of what they really need. And guilt is a very strong motivator in both restricting as well as purging. And this really has its roots in how we feel about food in general, right? And like Sukhadas right at the beginning, well, Indians eat for all occasions, and it's and eating is a very social, interactive process. It is meant to nourish, and when there is guilt, when there is negativity associated with food, it results a lot in people trying to restrict they're trying to eat or trying to compensate for it in other ways. So I'm just going to say again that eating has to be about joy. It has to be about what we enjoy.
Okay, I have a question for Dr. Sabina. What are the types of medications given to treat eating disorders? And is there any impact of these medications on dietary intake or metabolism?
Hi, Dr. Heron. Hi, Dr. Kashyap. Hi, everyone. Very interesting topic, right? Not very common in India. FDA has not, well, the American FDA has not approved, I don't think, any medicine for anorexia nervosa. There are a few medications primarily to deal with maybe the obsessive component, the depressive component, or the impulsive components of an eating disorder. And again, bulimia nervosa would be the one that would probably respond best to these medications. SSRIs, things like fluoxetine. And frankly, what Dr. Heron was saying, that nobody seemed to be interested in her, she had mentioned towards the end of her slides, there isn't much data out there. So it's very hard to find. Indian data is very close to zero. There are a few articles. I'm not saying people haven't tried, but I think it's very challenging to find. So evidence I've looked at is from data coming from abroad. And it's, like I said, SSRIs. There is a mention of olanzapine, which is an antipsychotic medication that can be used. But again, it will be quite interesting if a patient was to comfortably take olanzapine, which is the most weight increasing medication that I'm even aware of. So, but it has been used for those individuals who are who do not have insight, or the severity of the anorexia is so bad that you feel like there really needs to be a medical intervention. How would it interfere with the metabolism or the inner functioning of the body? There is no evidence that these medications would particularly change how a dietitian would work with the patient, or they would have to, well, they would obviously have to monitor how much weight gain is occurring, because these medicines can cause some rapid weight gain. But I don't assume, or I don't predict there would be any serious issues as far as a dietitian working with a patient and trying to get them to at least 80% of their weight. So to answer that, yeah, there is no worry over that. If the pros and cons, right? If the pros outweigh the cons of taking the medication, I have had patients tell me, no way am I going to take a certain medicine. So then you try to find a balance and see, this would be outpatient setting, of course, where the weight gain would be nil or close to nothing. So you do try to work with them. Again, SSRIs are the only ones I could find. Fluoxetine, sertraline, fluoxetine primarily. I didn't find much on other medications. Bupropion is another medicine, but that again can increase your risk of seizures. So unlikely to be used, but is actually a very good antidepressant.
If I could add to that, with anorexia, I would absolutely agree. There are no medications that show any evidence, because the power of weight gain takes care of all the problems. Increasing, you might think appetite stimulants would be helpful, not effective in anorexia, because it's not, ironically, it's not about appetite. Often patients have a very strong appetite, but their control. And I agree, SSRIs, there is evidence in the treatment of bulimia that it can be helpful. And in outpatient in the US, often SSRIs are offered to the patient with anorexia and maybe some anti-anxiety meds if they're willing to take it, just to reduce the suffering, because it's so difficult for them to, you know, basically be forced to gain weight when they have not totally signed on, which is usually the case.
So I think all the three panelists have also mentioned them that in the talk as well, that a multidisciplinary approach is very important. You can't look at it in an isolation, and that's very important for patients with eating disorders. Also, you know, just to point out to what Dr. Sabina has said even in her talk, that there's very little Indian data, and this is a forum. There are around 18% of our attendees today are working in the field of eating disorders. So we should come together and work towards probably conducting studies, researches in this area, so that we have something to talk about in the future as well. Our next question, I think Dr. Marcia has already addressed that question. Are there any deficiencies, nutrient deficiencies that you see? And ma'am has said that, the body is designed to deal feast and famine, so there are rarely any nutrient deficiencies. But with respect to that, are there, like, what guidelines would you use? Like you've mentioned about 500 calories and 300 calories addition, subtraction. What guidelines would you use for planning a diet for patients with eating disorders? And how does one ensure that because of these purging behaviors or, trying to binge eat, how does this ensure that all the nutrient requirements are met in order to reduce the risk of comorbidities?
The interesting thing is one cannot ensure any of that unless the patient is in a hospital residential program where their eating is totally controlled and managed by professionals. So with adolescents and younger, we're training the parents to ensure that the patients are eating adequately. And normal eating is, as I'm trying to make the point, is simple. We already know how to do that. Everyone knows what it looks like. It's not complicated. These patients actually know. And usually it's about organizing their eating. Many patients with eating disorders overeat fruits and vegetables because they're low in calories. And they may try to fill up on those things. And, it's interesting when we're talking about vitamins and minerals, dietitians will know fruits and vegetables are important. Many people, just the general public, probably don't eat enough. People with eating disorders often eat too many.
So you would look at the balance of all the food groups in order to meet the requirements. Are there any supplements that you end up using with these patients quite often? Or you would first try and meet requirements to the dietary sources, and then, if need be, add on a supplement if required?
In the US, most patients are low in calcium. And I'm speaking of patients with anorexia, and the long-term medical consequence of anorexia is bone disease, osteopenia, osteoporosis. And I do talk a lot about this with my patients, because you only have the window of adolescence to develop your bone density for life. And if your starvation has affected your hormone balance, it's well established that losing bone density as a teenager at rates that someone at age 80 might be losing bone, that these people go into young adulthood with, as one of my patients who was a young medical student was told, her bones look like an 80-year-old woman at age 25. And I myself have osteopenia from my course of anorexia when I was a teenager, and there are no treatments. Right now, there are no treatments for osteopenia or osteoporosis. Occasionally there's an experimental one, and my doctor and I'll try it, then I'll get a call, stop taking that med, it causes heart problems. Okay, I'll stop taking that med. So I tell patients, this is a condition that you could have for life everything else recovers. The heart, the brain. It's pretty amazing how good we are recovering from famine. So, and patients in the US, there's this anti-dairy product, anti-milk. Milk makes me feel full, hurts my stomach, and so do a number of other things. So it's popular for patients not to be using any dairy products at all, drinking soy milk or almond milk. And the food plan, if you look at the details of it, that I don't care how the person gets their calcium through food or a supplement. And if you're not having 3 dairy products a day, I say, let's talk about calcium supplements with a little vitamin D to improve absorption.
I just wanted to add, in the Indian context, it's vitamin D deficiency too. Every single patient that I encounter, I ask for a vitamin D level, and it's invariably low. And they don't have an eating disorder, so I'm not even looking for the eating disorder, and they still have it. Right. Yeah, especially in Bangalore, where we barely have any sun, which is in South India. And the other point I was also going to make is that it's not only in the United States, and in India also, you have the almond milk, there's all kinds of supplements people are now getting into, especially during this lockdown pandemic where everything is available online. You're not going to shop, and people are exploring new options. So you have people trying out very interesting things which actually are detrimental. There is this whole concept of even simple things like haldi, which are not haldi, is turmeric, which is not supposed to be used in large quantities, is now being used in larger than required quantities to, I don't know, prevent them from getting the pandemic. So I think it's a worldwide phenomenon, and it's not, even though we are not the developed nation and we come under the lower middle income category of countries, we still have people that are, like you mentioned, those people floating around with an eating disorder, even though they may not have the one would assume that, oh, because I grew up if I grew up in the West, my chances of getting an eating disorder are higher. And that's a very common notion that's out there. How can you have an eating disorder when you are living in a country of poverty or where there's malnourishment here? So even though these products are expensive, you will find that people are not going for the easily available milk. They are actually looking for the 100 rupees, 200 rupee cartons of alternates to almond milk, and there's several others which I don't even think are quite edible, but
I agree.
People go for them.
I'd like to say a few things in response to that. We're so much on the same page. It's fun. I'm so glad to hear you test for vitamin D. And one point I like to make about supplements is it's possible to take too much, and which can be extremely detrimental. We see in the US people taking too much vitamin D because it is the hot nutrient. You test most people and they're low. There's some question about whether our norms are set too high. It's possible. Too much vitamin D causes a loss of balance. And so I don't recommend taking large doses of vitamin D unless you've been tested, because you might not have low vitamin D, and aiming for, I would say, from the way I read the literature, low normal is better than high normal with vitamin D, because there just hasn't been much research on it. High doses of calcium are very dangerous too. So I say about nutrition, too much, too little will kill you. It's the middle road that I'm helping you walk. And about the prevalence of eating disorders, it is fascinating of how it tracks economic development around the world. And so does obesity. They go together, actually. And round it goes. I often ask people in the West, because they know more about, I'll say, where do you expect eating disorders were first a problem, Japan or China? They'll think for a moment. Sometimes they get it wrong, but of course the answer is Japan, because of economic development occurred earlier, and westernized economic development occurred earlier in Japan. Now in China, it's more of a problem. So eating disorders track, and the literature I've looked in India, you could look at the same. It's economic development. And in the US, you could look at population groups. It's economic development. Rarely does a extremely poor person where food is at a premium has an eating disorder. It's when there's plenty of food and one can make choices that we get into trouble in this modern world.
Right. So for a developing country like India, or we're almost like on the verge of like being a developed country, we have a double-edged sword of SAM at one end, which is the severe acute malnutrition and eating disorders on the other end. So yeah, and like you said, it's quite crucial to track that at early on in that adolescent phase, because sometimes the damage that is done at that point is going to be permanent. So it's very important that we look at our patients when they come. We've discussed the signs and symptoms in our talks, and very important for dietitians who are looking at adolescent age groups, try and identify those and refer them to the right people. One of our questions from one of our audience members is, I think Dr. Himani could possibly take that. Are there any scales that are available that would help dietitians identify eating disorders in the patients that they see? And if yes, are they licensed to use the scales that are available? Are they freely available for them to use?
No. So there are a couple that I know of. So one is called the Eating Disorders Examination Questionnaire, and the other is an Eating Disorders Diagnostic Schedule. I think the EDS may be licensed, but I know that I have seen copies float around as well. So I don't know if Dr. Marsha or Sabina want to add to that. But both of them are self-report. So it just means that the individual himself or herself fills it. So yeah, it's quite handy and quite easy to use. But I don't know if
there's a British one. There's a British one that's even simpler, just 7 questions, and that's just widely available. And I can send that around.
Sure. Dr. Sabina, would you like to add anything?
I was actually going to say something a little different. I was like, try to, if there are students in listening to this, it's better to understand the diagnostic criteria. I know there's a lot of controversy about which should you use the DSM, the ICD, and every time there's a conference, people are out there saying, oh my God, the DSM is all wrong. But as a student, as a young emerging dietitian or any practitioner in mental health, it's really helpful to know the diagnostic criteria, because you may not be able to access some of these scales which are usually expensive, and none of us can afford it. Even the MMSC, as if you're, I don't know if you know, just a mini mental status exam which the world thought was freely available is actually copyrighted. So my suggestion is, if you can't get a scale, just if you go online, there's plenty of DSM-5 criteria of every single eating disorder. Know them well. So if you know them well, it's not going to be very hard to somebody. Even I saw a question out there saying, how do I know difference between normal eating and an eating disorder? Just if you know your criteria, it's really not very hard to figure that out. So even if you don't have a scale, it's easier if you just knew the criteria. And you have to know the criteria.
The DSM is written so clearly. You don't have to be a psychologist or a psychiatrist to understand it. I know many of the people who are on the committee. It is so clearly written. It's one of my favorite books.
Right.
So I wanted to ask Dr. Marcia that generally, as anorexia as well as bulimia nervosa have got multi-organ impact. So whether it is our endocrine system, whether menses are completely affected, or it is the GI, gastrointestinal tract, whether esophagus or the colon, those particular organs are affected, or whether it is the bone health. So what I wanted to know is, I mean, once the rehabilitation begins, do the entire systems get back to normal? And if yes, how long do they take, or it's individualistic?
It's a really good question. One of the challenges in treating anorexia, of course, the GI system is very malnourished, but it's the gatekeeper to renourishing that organ system and the whole body. So most patients with anorexia are going to suffer at the beginning, and important to tell them that. I expect you to feel full. I expect you to get constipated. I expect you not to be hungry. I expect your belly to hurt. When will this go away? Probably not until your weight is restored, though it will get better as your GI system slowly recovers. I say something like this. If I had 3 wishes that God would grant me, the first would be world peace. The second would be correct greenhouse gases. The third would be my patients would feel wonderful following my food plan at the beginning, but none of my wishes have been granted yet.
Right. I have a very interesting question from one of the students, and it's a very naive question, but it's quite relevant. So what she says is, since weight stigma, oh sorry, where did it go? Yeah, since weight stigma is also an eating disorder, and I got to know that if the patient has a right to decline if he or she is asked to check weight. So emotionally and psychologically, it is empowering. But what if I really need to check the weight, as most of our diet plans for clinical conditions at undergraduate level requires anthropometric measurements, like your height, weight, to calculate the ideal body weight, BMI, etc. So how do I go about that in my practical scenario?
I'll take that on. The other speakers may have some ideas about that. If the patient is an adult in the US, you cannot make them take a weight if they choose not to. And I would just accept it. They will start asking questions about, do you think I'm eating too much? I don't know. Do you think I'm eating too little? It's hard for me to tell, because one's human dietary needs for calories is such a wide range. I can't really prescribe a calorie range for you if that's what you want from me, if I don't know what is going on with your weight. It's interesting with the COVID, and I think probably many of us, all my sessions are online with patients now. I'm not seeing them in my office. And so this means that I'm talking with patients about checking their weight at home. And that's very interesting, and something usually in the past I would have said, no, just in my office with my fancy scale. In fact, some of my patients say, thanks to not seeing me in my office, what they miss most is my scale, because I had such credibility with them, and probably good for them to get over their association with confidence in my scale. But it's a person's choice. It's a person's choice, and it's really important not to fight with patients. Earlier in my career, I fought more. No point now. I'm just, if that's how you want to do it, I can help you as much as I can. And I would want to explore, and maybe you talk with your therapist about what are usually a sound of fear that patients don't want to know their weight. Though the questioner is raising a good point about weight stigma, and many patients who are naturally large have been, they feel have been, and probably truly, mistreated by health professionals who are judgmental about their weight. And I make a real point not to be.
I think that would be the same thing even in the Indian context, right? I mean, I could be a little more pushy in India because you have to get on that scale. I'm the doctor and you're my patient.
Oh, the doctors are pushier than dietitians anyway, yes?
So, or you could try to collaborate, and it would be the same thing. And when they stand and don't raise your, we are a more expressive society. I was in the South, right, at Duke. So I think I was most expressive. It was just too much expression in the whole of North Carolina.
Of course.
Yeah. So it's, I think just when you see the weight, sometimes when you see the BMI or when you calculate, and don't look shocked, try to be very neutral, and like Dr. Matsui was saying, that if they talk about is it too much, is it too little, don't say anything that would make them worsen the fear. I think, like she said, working with a psychologist on the cognition behind that would eventually bring them to accept that standing on that scale and not being afraid is a part of getting better. The other thing actually was why I wanted to say something was, once the health gets better and the brain starts working again, when the nutrition is much better, then they start to think a little better and are able to understand the pros and cons and how things are going, and that they're actually unwell. Until then, they may not even notice they're unwell. So you might have to wait a little before they're going to get on the page.
So
Absolutely,
since Dr. Sabina, you spoke
I just
about,
want to add as well.
Yes.
no, please go on, please go on.
No, so I just wanted to say that I completely agree that there's absolutely no point fighting, like Dr. Marsha said. It is just going to worsen rapport. The person's just going to drop out of treatment, and it will be years before we them back in treatment again. So it really is about taking it slow and exploring how they feel about it, and letting them have some sense of control, because that's one of the things that's associated with eating disorders, right? The feeling of a lack of control over one's life and one's eating and one's body. And if we are not actually letting them feel a sense of control, if we're going to be beating them down with this is how I think it should go, we're probably going to get nowhere very quickly.
So I think what you're also trying to say is empathy is very important when you're dealing with your patients. It's very important the way you talk to them, your body language, what your face says, the tonation, the tone that you use with your patients is very important. And that's going to make a big difference the way you're going to counsel. So it's not just about, a lot of the students have asked about how many calories to give. So calories would not matter. It's the counseling, the education that you're going to give your patients, that's going to matter much more. I think, Anagha, we can take one more question before we...
Yeah, so we can have actually this question for all three of them.
Yeah.
Is how are eating disorders perceived by the caregivers, particularly parents or friends and families? I mean, how do they perceive it? I mean, what would be the Indian and US perspective? All three of you can take it maybe.
I'll say just very quickly from the US, it's all over the map, either taken extremely seriously or not seriously at all. No standard. I think increasingly though, people are taking them more seriously. And we've seen an uptick in anorexia with COVID actually. Or is it that parents are around their children more, noticing they're not really eating, and many people are bringing their children into treatment now.
Dr. Sabina, Dr. Imani?
I can go quickly. I think I'm worried that in India, I don't think the parents are even recognizing, we're not even close to, even if a child has a BMI of 12, 13, and I don't think the parents are even aware. By the time these teenagers go and close themselves in their room, I think parents are not understanding until I say, hey, look at the weight and look at the height, there's some problem right there. So I think we are ways off from parents reacting. And bulimia is more common in India, not anorexia. So bulimia, you may never pick it up. And so by the time parents get to know it, and mental health is again stigmatized in India. So eating disorders is unheard of. Reaction is, what are you talking about?
Right. I totally agree. Many of the clients I've seen, the parents don't really get a sense of what's actually happening. Sometimes I think particularly in the socioeconomic scenario of, Dr. Herring was talking about how economic development happens. And I think the generation just before ours has been, or even the current generation, has just hit the economic boom. So parents are far more indulgent with children. So, picky eating, restrictive eating, binging, many of those behaviors don't actually get noticed and flagged as something that's out of normal. And often there's many of my clients talk about how that is completely invalidated the eating behavior. So it was either a lot of force feeding or a lot of shaming, ridiculing. Particularly there was binge eating and not just how much are you going to eat, and a lot of body shaming and things like that. I think it's very difficult to find really a sensitive response, and a lot of the work in therapy is about educating parents. And there's this thing of I'm only going to eat half a roti, and then the parents saying no, you must eat two, and force feeding and that sort of thing. And how to actually deal with the adolescent, the young adult who's experiencing a whole range of eating disordered behaviors. So yeah.
So I think today's discussion has opened a Pandora's box. I see a lot of questions, they are still coming in, but unfortunately the time is limited, so we would not be able to take all the questions. Anagha, would you like to say anything? Hello.
I mean, really, this topic, which is, as you said in the beginning, that it is really like, a few pages in the textbooks or in syllabus, and often it is left as option by many students, but it actually deserves a lot of attention, and we really need to look at it. And as even some of the audiences have written, that awareness is very important, and with that we took the initiative also of actually making our students prepare posters which can develop nutrition awareness. So that was also the initiative that we could took, but all three of us actually gave us really good insights of the Indian perspective as well as the US one. And yeah, thanks to all of you.
Anagha, can I just come in for a minute?
Sure, ma'am.
Yes,
ma'am. So I think thank you all the three experts. It was a brilliant conversation, and it has brought in such pertinent threads. To my mind, I think the conversation, the center point is the psychologist, who really has to be an integral part of the team. So the teamwork is the key word which emerges out, because I don't think so it is only the nutritionist or only the psychologist, and what Dr. Shibani said, that, counseling the parents. I think today the communication between the child and the parent, that's a very, very challenging area, especially, early adolescents, when they tend to become rebellious and they are not wanting to listen to the parents. So in every nutrition therapy, I think we always talk about the teamwork. So I congratulate IDA Mumbai chapter to have initiated this discussion. This is one area which has really not been picked up so much, in the space of nutrition, especially in India. And now I get to know from Dr. Marsina that even in US, we don't have a lot of data there. But I think this is one of the areas where we can probably explore more interaction, workout modules where the teamwork can be emphasized, look at some validated, concepts which can be applied in different settings. So I think very, very interesting session, and thank you all the three experts for being with us. I think the inputs were very valuable. Thank you.
Thank you.
So I think before we head to, so there were some questions in the chat box that how do we create awareness? And like Anagha rightly mentioned, that we did take an initiative to create an awareness in colleges across India. Just to let the audience know that we had entries from north, south, east, west, all the colleges. And we have participants like Dr. Marcia is aware, from Dubai and different parts of the world as well. So we're really glad that we took this initiative. So before we head we have three. So our judges were Dr. Sabina Rao, Dr. Himani Kashyap, and we have our ex-president of Indian Dietetic Association Mumbai chapter, Ms. Nazneen Hussain. So over to you, ma'am. I'm going to display the posters. We had around 92 posters that came in, and we're going to announce the winners now. Are you able to see? Yeah.
Yeah,
Please
I
go.
just like to say that fantastic webinar, and Dr. Marcia, Sabina, and Dr. Kashyap. I think it was fantastic, and you know, this is a new topic, and you can look at these posters. Actually, I spent at least 3 hours looking at it because it was really intriguing. You know, it was fun. I had so much fun just evaluating all of them, and students, you all have done a fantastic job. You all have covered so much of depth. There is so much of science in this whole in all these posters, and we will make sure to use all these posters at every level.
Mm.
Yeah.
So
So yeah.
we're going to quickly show you the posters, and then at the end we will announce the winners.
You know, it was really hard because this time they've also brought in new eating disorders like the orthorexia, which was interesting. They did a lot of nice stuff on Pika, and I think a lot of awareness is the word to go, because these topics are very rarely spoken even in India. So I think, but they very much exist.
We're going quickly now because of the paucity of time, but we're going to put some of these posters on our Facebook. So please feel free to go there and have a look at it. Some amazing posters.
Yeah.
Yeah. Are you all ready to see the winners?
Yeah.
Ma'am, please do the
So
honors.
may I request Dr. Marcia to please declare the winners? It was a tough fight, but I'm sure somebody has to win. But I think everybody, whoever's made these posters, has done a fantastic job. Yeah, so congratulations, students, and all to all the contributors. Over to you, Dr. Marcia.
Oh.
That's a consolation prize, ma'am.
Ah, right there.
Yeah.
You know, I'd like to add that in the U.S., and there were several questions about how do you spread the word and let people know about the risks of eating disorders. It was this kind of education that these posters, and when I started work at Dartmouth College in the mid-'80s, this is the kind of work we did, education about eating disorders, so people can self-identify if they need help and if their friends need help, and it was very effective. It's interesting now, everyone knows about eating disorders, or so it seems, so we don't need to do this. We need to do the next step. Congratulations.
We have 3 winners, ma'am. This is a consolation prize, which is Miss Krisha Shah from SVT College of Home Science.
Wow, I'm extremely happy.
Yeah. Second winner. Sorry. Are you
Quick,
able to see the next slide?
Yes, Sugata, you can move on to the next slide.
Yeah. Our third winner, or at third place, we have Sakshi Patil from College of Home Science, Nirmala Niketan.
Excellent.
Our second winner, she's actually drawn it with her own hand and then taken a picture of it. So this is my favorite poster. Farzeen Bhatkar from SVT College of Home Science.
Excellent. Wow. I need to give a virtual clap.
Yeah. And at first place, we have Miss Sylvie from Punjab Agricultural University.
Okay.
So we have 4 winners, and because we had so many posters, we decided to do an LEC Choice Award as well, which is the core team of Indian Dietetic Association Mumbai chapter. And the winner of the LEC Choice Award is Miss Riya Desai from SVT College of Home Science again.
Excellent. I think I'm going to clap loudest.
So just to point out that Dr. Jagmeet Madan is the principal of SVT College of Home Science, and that's why ma'am is rejoicing the winning entries. Yeah. So I hope that this is going to create a lot of awareness. I'm sure that the students also had a good experience working on these posters. They've gone and actually read and put the reference at the bottom as well. So it's been a good learning experience. Dr. Sabina and Dr. Himani, thank you so much for judging these posters. Would you like to add anything?
I just want to say that very creative. My daughter loves art and she does art of her own, and she frankly sat down with me and I was looking, and it was a lot of fun sitting with her and saying, oh my God, such creative work. Just beautiful work, lot of effort put into it, lot of creative people in your group. So that's good news, because I think we're going to need creativity in India to get the message across. So congratulations and all the best to all the participants. Even if you didn't win, it's perfectly fine, because I think, like Ms. Hussain said, these posters can be used all over the country. So I think good work done, good work.
Yeah.
I totally agree. It's so creative. I was actually thinking there are so many, and I had a bit of a time crunch. I was thinking, how am I going to actually go through all of these? But it was such fun. I just enjoy going over them. There was a lot of effort to weave in knowledge and really innovative ways of doing that. And it was fascinating looking at how there were so many different perspectives, so many things that we wanted to highlight. So yeah, really enjoyed and quite hard as well. But yeah, great effort, everyone.
Yeah, thank you so much, the panelists and the judges. So before we end today's session, I would like to invite, if any of our senior members, Kopikar ma'am, any of you would like to comment, Anjali ma'am, I think we have Dr. Meena Mehta as well. So Meena ma'am, any of you who are there in the audience and would like to ask or comment before we conclude the session today? I think ma'am is not there. Yeah, over to you, Jayashree ma'am.
I take this opportunity to thank everyone, every panel member, our very own Dr. Jagmeet Madan ma'am, Dr. Himani Kashyap, Dr. Sabina Rao, and Dr. Marcia for being here with us and speak to us about the topic which is rarely talked about, and especially here in India, where eating or not eating is very, very okay. Like we really have love for food, and we love our children to be, chubby tits, rosy lips. That's what we call. And this was the need of the hour, and our young team who has done a fab job. And thank you so much for contributing and making us aware as dietitians also. And to my young students who are participating here, I would say that take-home messages, every patient that sits in front of you, we should be talking to them as if we are a therapist and a counselor. That is what our role is, rather than, sitting high up there on the chair and, just sermoning them about what they are supposed to eat and not supposed to eat. Congratulations to all the participants who have done such a fab job. And girls, trust us, we will give you the platform. We will be showcasing your work on our YouTube channel as well as our Facebook page. Thank you so much, Zamrud, our convener of the chapter. And once again, encouragement to all the young IDA members, Nazneen, Sukhada, Anaga, who have been the conveners of the program. Thank you so much. And thank you, Dr. Marcia, for associating with us. It was a pleasure hearing.
Yeah, I just want to make
you, Sukhada.
Yeah, quick addition. I would also like to thank Ms. Sushila Sharangar to connect us with, ma'am connected us with Dr. Marcia Herin. So I would like to thank her as well on behalf of IDA Mumbai chapter. And last but not the least,
has done a lot of work, I suppose, in this area. So we should really thank her for
as well. So I think this is just a beginning. We are going to come up with more programs perhaps on this topic in the future. And really thank you everyone for joining us today. A quick announcement for the upcoming programs. As it was announced at the start that the theme for this year is severe acute malnutrition and Poshan Ke Paudhe, or the medicinal trees. So we're going to have sessions on 14th, 15th, and 17th of this month. The details of that will be shared on our Facebook page soon. So do join us for those sessions as well. And students are keen on knowing where their certificates are going to come. So we're going to share the feedback form with you. And once you fill the feedback form, you will receive the certificate within 5 working days. So thank you all for joining us.
Thank you, everyone. Thank you so
Good
much.
night. And Dr. Marcia,
you
have a
very
good day
much.
ahead.
Thank you.
Thank you
all.
all the
everyone.
speakers and my team. Thank you so much.
It was a pleasure.
Thank you.
Thank you. Thank you.
Thank
Take
you.
care.
Bye.